Our topic today is preventing provider burnout in chronic pain and opioid use disorder treatment, hopefully relevant to you all. And this presentation does include slides from Dr. Lindsay from UNM's ASAP clinic. So our objectives today are to define burnout, compassion fatigue, secondary traumatization, and vicarious post-traumatic growth, to identify both system and individual level predisposing factors for burnout and fatigue, and to name evidence supported advocacy approaches, self care activities, and perspectives to navigate risk for burnout. So, starting out big picture, thinking, where we work in the Southwest and New Mexico in particular, we have a disproportionate degree in this area of traumatized populations. So, knowing that providing services to this population does increase our vulnerability to traumatic stress is an important part of taking care of ourselves as well as our patients. Traumatic stress includes vicarious trauma, secondary traumatic stress, and also compassion fatigue. So it's not just New Mexico in general, it's Albuquerque in particular, as the capital of the state is consistently ranked in the top 10 most dangerous cities in the US. And I think it's helpful for us to remember as providers that many of the patients that we're seeing are embedded within this context of chronic community violence, and their medical histories and their behaviors directly with us are likely to reflect that in many cases. So thinking of the young people of New Mexico uh, and youth with trauma exposure. At the national level, about 1 in 10 children have experienced three or more what's called adverse childhood experiences or ACEs. So that could include any kind of event such as an explicit, what we would conventionally think of as a trauma, such as sexual abuse or a very bad car accident. And it can also include chronically toxically stressful events. So that includes things like living with somebody in the home who has a severe mental illness that's unmanaged or poorly managed, or an acrimonious divorce between parents, these sort of things. So it could be either acute or ongoing. So in New Mexico, as compared to the national average, a little less than half the population endorses having experienced zero adverse childhood experiences. About a quarter have had one, around 10% two, and then almost 20% of the population has had three or more. So that's close to twice the national average. And in fact, Arizona was the only other state who had a comparable rate of adverse childhood experiences. So thinking first, who we're likely to be treating, just generally speaking, and then also recognizing that people who have particularly more than one or two ACEs are significantly more likely to develop a substance use disorder and or a chronic pain disorder. Unfortunately, there's a very strong red line between early childhood experiences of adversity and the later development of trouble with substances and chronic pain. So thinking, both big picture, where people are coming from, and then also how they present once they're in our office. Remembering that people from these populations often have really been disenfranchised from the healthcare system. This is a stigmatized population, not only at large, but also within the healthcare system specifically. So there can be a lot of behaviors that are, fearful or protective, and that might come across as being hostile or aggressive or antagonistic. So part of that is us understanding where it's coming from so that we can respond effectively for both ourselves and the patients. Because it's a population to work with that I think first of all is important to remember. It's a heavy weight for them, and it's a heavy weight for us to help them as well. So that's a big part of why we want to talk about this today. So in terms of just definitively separating these principles, burnout and compassion fatigue are technically two separate things. Since we're doing an overview today, we're going to talk about them alongside each other. But it is important to distinguish those clearly from secondary trauma and vicarious trauma. So with burnout and compassion fatigue, that has more to do with general job dissatisfaction, whereas with secondary and vicarious trauma, that's actually more about working with specifically traumatized individuals. In secondary trauma, it's a case where a provider is going to manifest symptoms that directly reflect a specific patient case, whereas with vicarious trauma, it's cumulative and it's more about long-term exposure to quite a lot of traumatic material, and that shows up a little bit more diffusely in terms of many different dimensions of traumatic stress. In terms of how the vulnerabilities to these different conditions, with burnout and compassion fatigue, it's usually related to workload and the environment, and it's usually additive over time. Whereas with secondary and vicarious trauma, it's more related to empathy and difficulties with upholding boundaries that are going to help us to work effectively and sustainably with traumatized populations. With burnout and compassion fatigue, a really major characteristic is a low feeling of accomplishment. We'll talk more about that. Whereas with secondary and vicarious trauma, it's much more similar to the visceral experience of trauma of patients themselves. So things like feeling out of control, powerless, anxious, overwhelmed, hopeless, and depressed. In terms of how we address these with burnout and compassion fatigue, usually the remedy is time away, vacation. It can mean changing work if we're not able to make work change in a way that supports us. Whereas with secondary and vicarious trauma, it's more than just time away. There needs to be a therapeutic shift in terms of how we take care of ourselves. And sometimes it means changing the work environment. Sometimes it just means a fundamental restructuring of how we approach our work and again, how we care for ourselves outside of work. All of these are very important to address. We all know that we don't have as many providers as we would love in this community, and taking care of ourselves and making sure we can stay in it for the long game is a really important part of caring for our patients as well as ourselves. So in terms of symptoms of burnout and fatigue, the way it shows up most often at work would be avoiding or dreading working with certain patients or populations, reduced ability to feel empathy, and that's not just about sort of effective boundaries, that's about a sense of sort of detachment or depersonalization where you're no longer really feeling affected by the difficult things happening to patients or families in a way that makes it more difficult to connect with them. Using a lot of sick days, not really having a sense of joy or meaning in your work. Cynicism and pessimism are very large kind of big picture ways that this shows up. And also, of course, lack of satisfaction with work, which makes sense if it goes along with all of these symptoms. In terms of the emotional and the cognitive, as well as the physical symptoms, there's a really large constellation of pretty non-specific symptoms. So if you're experiencing things like irritability and anger or sleep disturbances, that doesn't for sure mean that you have burnout, but it's something to consider when you're noticing these kind of just larger factor day-to-day feeling worn down and feeling pretty tired. These are some of the specific things that tend to go along with that and that often are characteristic of burnout. In terms of vulnerabilities that are associated with compassion fatigue, one of the biggest is the cognitive concept that the belief that your actions will not make a difference or that they never seem to be enough. So that's that feeling of Sisyphus rolling the boulder up the hill every day just to have it, go right back down to the bottom and feeling like we're starting back at square one can be incredibly demoralizing with this difficult work. Part of what contributes to that is experiencing problems with the system. So that could be just having far too large of a patient caseload or too acute of a caseload, too much overtime or extra work days. In particular, the systems level a lack of trauma-informed care or managerial support. So working within a system that it sometimes feels perhaps is working against you in terms of providing ideal patient care. Obviously, if we're experiencing issues outside the workplace that deplete us, that also makes us vulnerable to the challenges of the work that we do. Over-identifying with patients is an interesting one because it does happen quite a lot, but it can make it very difficult for us to be skillful in our work because it makes us less objective and less likely to recognize some of the blind spots that come up when we're working with populations that have a special place in our heart. Sort of chicken and an egg vulnerability here is overlooking serious patient symptoms that then impact patient outcomes. This is one of these things that we see in the literature happens once people already are experiencing compassion fatigue, and then of course it compounds it because there's a lot of guilt and shame that goes along with that. In terms of how we prevent or ameliorate compassion fatigue, one of the most important pieces is, as with so many things in life, recognizing the symptoms and acknowledging that we may have a problem. And then learning to ask for help. There's some interesting parallels between military culture and healthcare culture here in the literature where we see that people think that in order to be a team player, they should never acknowledge that they're suffering or ask for time away or anything that could be regarded as less than stoic. But the reality is that preserving ourselves for the long run is actually the best team player maneuver that we could really pull. And so part of that is speaking up for ourselves so that we can set that model for other people on our team as well. Being aware and accepting the limitations of our job and also of ourselves. So just recognizing that we are human and that we're not going to be able to accomplish probably everything that we'd like to with a population that's challenging and that's a meaningful population for us. And part of this is also learning to say no in professional contexts, and that can be really difficult for providers who are drawn to this work because it's a population that they care a lot about. But again, this is about preserving ourselves for the long run. In terms of validation, recognizing that our pain is understandable, it would be odd for somebody to work with these populations and never feel any distress about it because it is just a fundamentally distressing line of work in certain respects. But recognizing that and that it's not about something that's a unique flaw in us, but that it's part of the work that we do can be a really important part of making sure we're managing that pain effectively. We also want to kind of go on the offensive and remind ourselves proactively daily that what we do makes a difference and that what we do matters because our brains are very good at forgetting that and focusing on all the things that we haven't done and all of the things that we're not doing as much as we'd like. So, really making a proactive habit of remembering that what we do matters. And on the more technical side, maintaining discipline and daily responsibilities and duties. This is really about time management because one thing we see in the literature about both burnout and compassion fatigue is that people tend to become vulnerable by being caught up in these small details, spending a lot of time on tasks that ultimately are not going to make a larger impact. So, this is really in many ways about time management, making sure that you're prioritizing urgent to strategic tasks and making sure that your effort is going where it's going to make the biggest impact. Taking time out during the day to renew and recharge, that's about reminding yourself every day within the work environment that you do have time to take care of both yourself and your patients. Because sometimes we can get into that autopilot mode of always eating lunch in front of the computer and never taking time to take a little walk or say hello to our coworkers. And then that becomes more of our own experience where we start to believe that we don't have time to do these little things that are important to keep us healthy. And then on this front, a very important one, if you've ever provided psychotherapy or been in it, you've probably heard some version of distinguish between what you can and cannot change or control, because this is a really important part of staying sane in a system that often feels like it's working against us. So being able to recognize what are the things I have control over here and what are the things that are outside of my control. So, on that note, I wanted to share. I think this is a really helpful graphic from the National Academy of Medicine that takes a sort of ecological view and shows that patient well being is sort of at the heart or is nested within the clinician patient relationship, which further is held by the clinician well being. And then that is ensconced within these much larger sort of macro factors like society and culture and learning and practice environments. And you'll see there's only a couple of blue leaves there. Those are those macro factors that are within our control, so personal factors and skills and abilities. And then everything else, things like rules and regulations or organizational factors, those are really above us in a certain sense. So it doesn't mean we can't impact them, but it does mean that unless we're in unique leadership positions, we're unlikely to be able to have a direct impact on them. It would be more about long term strategic advocacy. So, to that point, I wanted to draw on some of the qualitative literature that reflects some of these considerations, the systemic and the individual interplay. And one of the biggest themes in the qualitative literature from providers who work with opioid use disorder and chronic pain patients is recognizing that systemic and administrative barriers are a huge contributor to burnout. A big one is hospital policies that negatively affect patient care. In particular, this was manifested in the feeling for providers that they needed to discharge patients as quickly as possible in acute settings, particularly without having any kind of plan in place or resources in place to make sure that their recovery was sustainable outside of the facility. And so that revolving door feeling, that's really that Sisyphus thing again, right? Where you're pushing this very heavy boulder up the hill. You're working very hard while the patient is in your care to get them stabilized. And then you see them walk out the door and come back in the door maybe just a few days later in a deteriorated condition because they've gone back out into a community that wasn't able to sustain that stability. Similarly, limited resources or restrictive policies that create barriers to care. This was a really strong theme with addiction medicine physicians. So, when there were policies that limited use of buprenorphine or methadone, this was one of the most roundly endorsed considerations for burnout. And they were saying, you know, we know what's right for this patient, we know how to take care of them well, but because of regional or organizational regulations, they're not allowed always to administer medication in the way that they know would be best. So that's something I know we talk about a lot here on this Echo, and I think we often hear the frustration here as well. Also, community resources that are restricted or unavailable, or lack of coordination with the community resources. And that's that frustration of doing your best to set a patient up for a long term recovery and then just watching them slip through the net. So that can really lead to feelings of powerlessness and hopelessness, which thinking back to the beginning, that's a real vulnerability factor for all of the traumatic stress and the burnout and fatigue conditions. So this was from a more quantitative survey. This was with physicians working in interventional pain management. And 67% of these physicians responded that in house billing was one of the primary factors responsible for their felt sense of burnout, whereas 73% responded that electronic medical records, EMRs, were one of the main causes. So it wasn't exclusive, it was ranked. But just thinking again back to that idea that often it's these things that are really over our head and outside of our control, our immediate control, that are wearing us down day by day. So this is actually an almost wholesale excerpt from a really, really great book that I recommend if you're interested in this. This is Leaving It at the Office by a couple of psychologists who do a lot of work in burnout and healthcare settings. And this is from a section where they talk about the importance of cognitive restructuring and a sort of perspective-based approach to burnout prevention. They're very eloquent, they're very succinct, so I'll take that piecemeal from them. First, recognizing the grim truth that organizations create much of practitioner exhaustion and demoralization, refuse to blame the person when institutional causes operate. So once again, going back to that idea of recognizing what's out of our control and not internalizing it as one of our own flaws. Then beware the toxicity of chronic moral stress. Repeatedly rendering suboptimal care erodes your soul. This was a really strong theme in the qualitative literature. There's almost this feeling of attenuated moral injury for providers who know what kind of care they want to provide and just feel that the regulatory environment or the logistical environment of their organization or region has prohibited them from providing that care to patients. And it can be easy to become passive and just accept that. And we want to make sure that doesn't happen, to keep fighting a potentially uphill battle to make sure we provide the best care that we can. And resist the pressures of managed care to define yourself as a nameless and disembodied provider. Maintain your individual identity as a distinctive practitioner of healing. So this is really about making sure we don't succumb to that feeling that we're a cog in the machine, returning to that idea of why did we get into this area of practice? Why is it meaningful? What makes us individual? What is sort of our own brand as a healer? Searching for ways to create greater freedom and independence in your work. One thing that we absolutely know from the burnout literature is that people who are more in control of their workloads and schedules experience less burnout and also more work-life satisfaction. So anytime that you can really create more autonomy for yourself, more of a sense of control over your work, that's going to be a huge preventive factor in itself. And then to borrow a metaphor from the medical model, beware of false interventions and short-term fixes in dysfunctional institutions. Treat the systemic roots, not just the acute symptoms. So again, remembering there are these overhead factors. We can impact them, but it's a long game. We want to make sure we're not just putting a Band-Aid on an illness that requires much more extensive intervention. So in terms of a system approach to well-being, these are some recommendations from the National Academy of Medicine from their task force on clinician well-being. Creating positive work environments, obviously where we spend every day is going to affect our well-being. Talking with colleagues, leaders, and advocating for change. So this again is part of making it an open conversation. So changing that culture to one where we can openly talk about how important it is to care for each other and ourselves. Similarly, addressing burnout in the training in the early career stage. So we're starting to change that paradigm from the bottom up. Advocating for trauma-informed care policy and procedure. This is an important part of making sure that we can care for patients, particularly from this population, in the best way possible. Reducing tasks that don't improve patient care. So that goes back to the administrative burden. Similarly, improving usability and relevance of health information technology. Again, the EMR, the billing, thinking about where we're spending our time and is it at the top of our skills pyramid and what's most meaningful to us. And then similarly, reducing stigma and improving burnout recovery services. So going back to that idea of making it an open conversation. We've looked mostly at the system level piece, which I think is really important. I'm going to spend just a couple minutes on individual level preventive considerations. So when we think about coping, people often have this idea that it's this passive kind of getting through something sort of experience, but I think it's helpful to remember that etymologically it actually comes from the French coup, which is to meet in battle. And for me, that's a helpful way to remember that it is very much an active stance. It's sort of about being proactive and taking the offensive and making sure that we hold on to our well-being and protect it. So part of that is making a conscious effort to solve personal and interpersonal problems, making sure that we're not just passively accepting it, and seeking to master or tolerize stress and conflict in an effective manner. So about being skillful and again, making sure we're directing our energy to where it's most helpful. And remembering that when we take an active stance in coping with our own stress, it's not just about containing the potential negative impacts of working with traumatized patients. We also can be effective models of coping for our patients, and that can be really powerful. Medical and behavioral health providers often are or can be models for their patient, and when they see us taking care of ourselves, that can be a powerful message of the importance of self care to them. In terms of individual self-care strategies, I'll say for myself, I get frustrated when organizations tell me how to do self-care. I think it's a little bit of a talking point sometimes. So I just wanted to share the domains that have a good evidence base. So this is, what you might choose to personalize within. We know that close relationships are absolutely the most important factor for most people's well-being. Of course, the boring but effective healthy lifestyle factors, so sleep, exercise, time away, eating well, making sure that we are making time for hobbies and activities that are meaningful and replenishing for us. Mindfulness and meditation activities can be very helpful for some. Pursuing spiritual development, not just for the philosophical benefits and the spiritual benefits, but also for the community. That's a big part of the research literature on why that's so helpful. And then remembering to personalize our self care to make sure that it's working for us. One piece that I really liked here from the literature was the idea of counterbalancing. So that's the idea that if you're anything like me, a lot of the work that you do is pretty in your head, on the computer, in meetings, that sort of thing. So you want to try to counterbalance that in your self care activities with something that's very tangible and concrete, where you get to see the results of your actions right away instead of many months down the line diffusely. So it's this kind of chop wood, carry water, doing tangible activities in the real world to counterbalance all of these kind of diffuse long term things that many of us do in our work. And then remembering to convert those intentions into actual behaviors. We know in healthcare, it's one thing to set a plan to become healthy, it's totally another thing to actually follow through on it. So that sense of accountability. So we've talked about specific strategies. In wrapping up, I want to talk about some of the more higher order interventions. So this is more about developing a philosophy that's going to hold you and working with challenging populations, helping you to remind yourself how your work is unique or why it's meaningful. If you've read Viktor Frankl's Man's Search for Meaning, you've probably come across this very famous quote, which is, "What is to give light must endure burning." And Frankl is more eloquent than anyone else I know about that idea of recognizing when we are experiencing pain or experiencing suffering, what the meaning is within it. And that's the idea with many of these philosophies that go along with working with these populations. So I'll just briefly touch on a few of the themes that went along with that from the qualitative studies. Providers definitely mentioned that when they engaged in meaningful work, they recognized that it increased their resilience. That included making concrete differences in their patients' lives, often by starting them on evidence-based medications. Being able to provide patient-centered care even within an environment that sometimes seemed as though it were working against that aim. Connecting with this vulnerable population in particular could be rewarding, not always, but in many cases, making those connections, particularly during a time of particular vulnerability, produced a lot of meaning making for providers. And in particular, working with patients who had experienced a lot of stigma and the provider being able to give a completely new experience for them within the healthcare system. Another piece there, and this is in wrapping up, in terms of how providers find satisfaction and meaning in those higher level endeavors, the advocacy, the education, and also the participation in a professional community. A lot of providers mentioned that when they participated in institutional quality improvement projects or other similar higher level advocacy work to improve patient care, that helped them get through some of the day-to-day challenges because they knew they were participating in the bigger sort of long game factors. I also wanted to share this quote. I thought this was great from an MD. It sort of reflected how I feel about appreciating the culture of advocacy among their colleagues because I think this is an unusual community. And this physician said, "I feel like addiction medicine providers are people who have a very strong sense of social justice, which is a pleasure and really important to me to work with people who are thinking about that in their work. And then also people who are interested in questioning the system and rules and trying to change it, which is also a very special group of people." And I agree with this quote very much. So to wrap up, I'll mention one last of those sort of philosophical interventions, which is the post-traumatic growth. Hemingway said, "The world breaks everyone, and afterward many are strong at the broken places." That's a great summary of post-traumatic growth. It's this idea that in addition, often alongside but sometimes instead of post-traumatic stress disorder, people often do experience a positive cognitive shift. And that can be about, it's very often about recognizing individual strengths that they hadn't before, having a new perspective on life, or appreciating life in a new way because of how they processed and were able to respond to the trauma. So, not the traumatic event itself, but their ability to respond and make meaning of it. And then lastly, just noting that alongside all of the other more difficult things that can happen to us when we work with this population, we can also experience vicarious post-traumatic growth, which is exactly what it sounds like, getting that sort of secondary benefit that mirrors the client's experience when they are recognizing their own strengths, having a renewed sense of perspective on life, greater appreciation for life, these sorts of really, really very big benefits. So I'll just mention there are a couple resources page here, just tips, strategies, activities for well-being, and then also if you're interested in a little quantitative snapshot of how you're doing on the burnout spectrum, there's the ProQual 5 self-assessment. All right, a lot of information in a short amount of time. Any questions or comments or thoughts on this topic?